Welcome to my channel. This is an online discussion of a short case, so it will have its own limitation of online discussion. Our young doctor, Drishya, will tell us something about this case very briefly, and she will start with the diagnosis so that my discussion will be brief and to the point.
Mitral stenosis, pulmonary arterial hypertension, rheumatic, no cardiac failure, no atrial fibrillation, no infective endocarditis, sinus rhythm. 12-year-old female, easy fatigability and breathlessness while going up the steps at school for the past 1 month. Okay while resting and the sleep was not disturbed. 2 months back had persistent cough, mostly during night and mostly it was dry, but occasionally blood-tinged white sputum was produced. Did investigation for TB and was found to be negative. No history suggestive of rheumatic fever in the past. No palpitation, no chest pain. No cyanosis or clubbing. BP, pulse, JVP was all normal. On palpation, apex at the fifth space at mid-clavicular line. Left parasternal heel. P2 is palpable and diastolic thrill at apex.
Thank you, Dr. Drishya. You have made a very pertinent point saying that sleep is not disturbed, because in mitral stenosis, the mitral valve is narrowed, so lot of blood stagnates in left atrium, then back pressure to the pulmonary veins and to the pulmonary venous bed. So there will be some seepage, and so getting up from bed to cough at night is expected, because at night we are lying down supine, so the most dependent part is the base of the lung. Here it is not happening, possibly because pulmonary arterial hypertension is protecting the pulmonary circulation from overloading. The child is female child. Mitral stenosis is commonest in females. And the cough was investigated for tuberculosis in this case, which is totally justifiable because prolonged cough, tuberculosis is a much more common cause as compared to very rare mitral stenosis. And the cough actually settled after the child developed easy fatigability, which means that the child stopped all these exercises. So the excess systemic venous return coming to the pulmonary circulation is curtailed. So the cough naturally came down. That is what we can assume from this history. It's true that almost 50% of mitral stenosis patients will not have a recollectable history of rheumatic fever in the past. Then palpitation is an important history because atrial fibrillation is very common in a mitral stenosis where the left atrium is big. But then it takes some time, so it is more of an adult thing rather than a child. Pulse and BP, since the stenosed mitral valve is not allowing all the blood to come to the left ventricle is receiving less blood than normal. So naturally, what is pushed into the systemic circulation is less than normal, so the pulse volume is likely to be low. And so is BP, where it is likely to be in the lower range of normal. And palpation finding of PAH and confirmation of PAH by palpation is very good idea in this case, because the auscultation shows the whole diastole is full of auscultatory events. So it is very difficult to assess pulmonary hypertension by auscultation in this case. So congratulations, Drishya, for making out pulmonary arterial hypertension by palpation. Now listen to the murmur. Whether it is diastolic or systolic, you will have to time with the carotid. But this particular quality of murmur makes it almost certain that it is a diastolic murmur of mitral stenosis. So without a second thought, you can commit that it is a diastolic murmur of mitral stenosis. Typical murmur of mitral stenosis is a rough and rumbling mid-diastolic murmur with pre-systolic accentuation ending in a loud first sound. It sounds like rup, 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 like that. So you will never mistake it for any other murmur. As shown in this picture, usually the mitral stenosis murmur start somewhere in the mid-diastolic with a opening snap. And then it goes on increasing in intensity and stops with the loud first sound. In this case, as is drawn here, almost the whole of diastole is filled with murmur, starting with some loud events at the region of second heart sound. Listen to this low-speed version of the murmur and see if you can make out anything in and around the second sound. With the diagnosis of mitral stenosis in mind, these loud events at the start of diastolic murmur is likely to be loud P2 and the opening snap close together. It possibly means severity because when the opening snap is very close to S2, the mitral stenosis is severe. And also the long murmur. Both these things actually point towards the severe mitral stenosis. Differential diagnosis, investigation, and management you can read from books. These books give a good account of mitral stenosis and the ECG findings. Thank you for watching.